from the RSNA. Welcome to Radiology Imaging Cancer Journal podcast hosted by Trainee Editorial Board. I am Yash Singh from Mayo Clinic with my colleague Brennan Thomas from Case Western Reserve University and Ghazal from Johns Hopkins University. Today marks the launch of an exciting journey where we will explore the cutting edge intersection of radiology and cancer care through the lens of this year RSNA theme, Imaging the Individual. Today, you will meet the brilliant minds behind the podcast series, a diverse group of trainees from around the globe who are shaping the future of cancer imaging. Thomas, Brennan, and Ghazal, would you like to introduce yourself, please?
Great, thanks, Yash. Hi, everyone. My name is Tom DeSilvio. I'm a PhD candidate in biomedical engineering at Case Western Reserve University, and my research focuses on developing AI methods for MRI.
Hi, Yash. This is Brennan Flannery. I am a fifth-year PhD candidate at Case Western Reserve University in the same lab as Tom. And I study developing AI models for both radiology and pathology in renal cancer primarily.
Hi everyone, I'm Ghazal Zandieh, a postdoctoral researcher in cancer imaging at Johns Hopkins with a primary focus on pancreatic cancer imaging.
Thank you, Thomas, Brennan, and Ghazal. So, our mission is to bridge the gap between the cutting edge research and clinical application in cancer imaging. This podcast series will explore how imaging the individual transforms the cancer care through several key areas like evaluation, prognostication, diagnosis, and treatment. We will discuss how advanced imaging technique enable tailored therapeutic approach based on individual tumor characteristics, patient anatomy, and molecular profiles. And we will explore how machine learning models are being developed and validated for individual patients' application, moving beyond population-based approaches to truly personalized algorithm.
Radiology Imaging Cancer is a peer-reviewed RSNA journal covering the best clinical and translational cancer imaging studies across organ systems and modalities, including leading-edge technological developments. So, welcome to the world of suspicious lesions and questionable segmentations. Let's dive right into our interview with Dr. Gary Luker, editor of Radiology, Imaging Cancer, the RSNA Journal.
We're really excited to welcome Dr. Gary Luker. Dr. Luker is a physician scientist with research interests centered at the intersections of cancer biology and molecular imaging. He investigates tumor stromal interactions in cancer that drive tumor growth, metastasis, and drug resistance. Dr. Luker applies multi-scale imaging methods to understand tumor heterogeneity and predict early response to therapy in models ranging from single cells to clinical studies. He serves as the editor of Radiology Imaging Cancer. How you doing, Dr. Luker? Good to have you.
Very good. Thank you for the opportunity to talk with both of you, and I look forward to our discussion.
Wonderful. So just to start things off, could you tell us a little bit about your background and how you got where you are?
Sure. Well, summarize so that our podcast listeners don't fall asleep. As you've said in the introduction, which thank you very much for your kind words, I'm a physician scientist. As a diagnostic radiology resident, I was starting to do research, but realized that I wanted to be able to ask questions. I didn't really have the skills and background to do. So in parallel with the clinical fellowship, I also did a research fellowship, learning how to do bench research. And I really enjoyed it and found that it enabled me to think about problems in medical research, in particular cancer biology, in a way that I hadn't been able to previously. So I've continued along that trajectory in my career. Originally, I was at Washington University in St. Louis, and I was recruited to the University of Michigan a little over 20 years ago to join the Center for Molecular Imaging here. And I've been a faculty member at the University of Michigan since then. When RSNA started what we call the suite journals, the artificial intelligence, cardiothoracic imaging, and imaging cancer new journals at the time. I was very intrigued and interested about the possibility of the imaging cancer position and being able to build, a new journal that really would address, I think, some very important questions in the field where we need to collectively in radiology have a very strong scientific basis for our work, starting in the very basic preclinical space and then extending that into translational science and clinical practice. And I've been fortunate, incredibly fortunate, I will say, to work with some amazing deputy editors, members of the trainee editorial board like yourselves, as we've really embarked together on what I think has been a very successful mission. And, I guess to brag on the journal a little bit, I mean, we are still relatively new, but, the latest impact factors we have, we're easily within the top 10% of all imaging journals in terms of impact factor. And I think very gratifying to me, we're in the top 20% of all journals listed in the oncology space. So I think we're reaching an audience, and I'm very excited about what we've done, but even more excited about the ways we can move forward together.
Yeah, totally. Thanks for that. Thanks for that information. So you're very interested, right, in the translational piece of radiology, and this year's RSNA theme is imaging the individual. So what does imaging the individual mean in modern healthcare today?
Sure. And I guess, not to change the topic for all the RSNA information and so forth, but I think of this more broadly as opposed to imaging the individual, we're really treating the individual. And imaging is a cornerstone of that, but it really needs to integrate into all of clinical practice. So that includes information about the types of drugs that a patient may have received, more investigational things such as next generation sequencing for mutations that may be present in the tumor. But all of that is focused on the idea that even though we may see hundreds or thousands of patients as part of clinical practice, each one is a unique individual that needs to have a unique course of action to help that person improve his or her health status, and then be able to continue, hopefully, happy, healthy, productive lives. So we need to tailor our imaging approaches and our treatment approaches toward the specific needs and really the endpoints that each individual wants. So as we think about, the future of cancer imaging, I think we really need to then focus on how do we take data that we get from larger scale clinical trials and clinical studies and really hone that information to target one specific individual at a time and provide the best quality care that we possibly can.
I'm really glad you brought that up, Dr. Luker. I see medical practice generally decided upon based on these large population-based studies. So how does this more individualized approach fit into that larger puzzle that we currently have of clinical practice?
Sure. I mean, any clinical trial practice, changing study needs to have enough participants in it to have the power to really make definitive conclusions. But I think even within that space, there's an increasing interest on understanding more broadly the exceptions, the people who don't, quote unquote, follow the rules of the trial. Sometimes those are people who unfortunately don't benefit the way others do. On the other hand, there's some who have remarkable responses. I mean, if we think about immunotherapy, for example, one of the really hot areas in cancer treatment, there are some patients who get no benefit whatsoever, unfortunately. But then there is a small subset of these individuals who get remarkable benefits from the treatment. And there's really an increasing focus on understanding why. And as we take our information gathered from hundreds or sometimes thousands of participants in a clinical study, then if we start to understand why some of those participants did really well or not so well, then we can move closer to the goal that we talked about just a few minutes ago about really providing individual treatment, individual imaging, and individual care for each person that we see.
I would imagine that it would be somewhat difficult to determine the why of why someone is not responding to a certain therapy or why they are responding to a certain therapy. A lot of these why questions we don't necessarily always understand. So what technological advances have you seen that have kind of unlocked this ability of us to determine who's going to respond best, who's going to be treated best?
Obviously, you raise a huge question as to understanding why may take years of research, but that's where really the breakthroughs come through. And there are a variety of technologies that really have played into this, both in the imaging space and in the broader medical community. In the imaging space, there are clearly technology advances in terms of just better quality scans, faster scans, scans with new radio tracers that can provide more functional and molecular information than we could have had even a decade ago. And that is huge. I'm not the first person to say this, but I think it's still true that any biopsy is really a failure of imaging, and that's a motivation for us to do better in terms of how we can functionally characterize a tumor and be able to provide enough specific information that oncologists can provide a very targeted treatment strategy based on the information that we supply them. I think more broadly in terms of just medicine as a whole, the ability to really capture the human genome, both in terms of DNA mutations, the transcription that occurs from tumors, and really starting to use that information to understand heterogeneity in a tumor. So a tumor is multiple subpopulations of cells all working collectively. And I say that because many times they are working collaboratively to drive tumor progression. There are different sites within a tumor. So there's heterogeneity within a single tumor. If you look at a primary tumor to a metastasis, there's more heterogeneity. And the tumor in patient one is not in any way the same as the tumor in patient two, even if they are the same general type of cancer, such as breast cancer, lung cancer, so forth. So really, our imaging methods then need to start to hone in on that tumor heterogeneity. How do we understand it? How do we diagnose it better?
I think there is something to be said of a public perception that if someone's diagnosed with cancer, it's one disease. But really, it sounds like from what you're saying that it can be multiple diseases in a single person, and across multiple people, you're seeing all sorts of different variations.
Yes. And I think even the traditional way that we think about cancer in terms of classifying it will change and is changing. So tumors that have a common mutation, and there's several examples of this, may all respond to the same type of therapy, even though one may be a lung cancer, another may be a GI cancer. So thinking about cancer in terms of how we might diagnose it, treat it based on the molecular profiles, I think may be ultimately more informative than saying, well, this is breast cancer, because breast cancer is multiple cancers, and you can make that same example for any one of them. So as we think about moving imaging forward in the cancer space, I think the closer we can get to that type of molecular diagnostic information, the better we're able to serve our community.
I think one of the ways that I've seen people try to advance this sort of personalized imaging is by incorporating information across multiple modalities at once. How has multimodal imaging technologies play a role in this new imaging the individual idea?
You bring up a great point. I mean, all one has to do is look at, say, PET scans. Uh, a decade or more ago, there were standalone PET scanners. That entity basically no longer exists. I mean, every PET scanner comes with a CT. So you have anatomic and functional imaging. Obviously, PET-MR is another idea. But I think that's where some of the work in artificial intelligence can really provide new insights, is taking information that comes from different scans, even at different times, and merging that information into a more comprehensive understanding of the tumor environment, response to therapy, and how tumors are adapting over time. So not just images that occur from a single scanner, but how do we go from, say, a PET CT scan, integrate MR information if you don't have a PET MR, and those are not incredibly common still, and then potentially leverage that with information from a different imaging agent altogether, say another PET radiotracer or a functional scan that has blood flow information. How do we put all that together? And that's one of the great challenges, and I think one of the great opportunities for AI.
Absolutely. And I think you have a very unique position as editor of Radiology, Imaging, Cancer to see all of this new technology develop, whether we're looking at something in the molecular level, functionally, or multi-modality. So to that end, what advances have you seen recently that really caught your attention, from the AI perspective, whether it's from improving an imaging modality or somehow like creatively incorporating them together? Could you talk about some of those advances you've seen so far?
Sure. I mean, I think there are multiple opportunities, multiple examples. So I'll just highlight a few. Not necessarily a single technology per se, but interventional oncology is, I think, a huge advance in the way that, imaging and radiology departments now play a very active role in treating cancer. So approaches to treatment of cancer that years ago might have required a surgery or something far more invasive are now done non-invasively or minimally invasively through interventional techniques where one can deliver localized, dose of chemotherapy or radiation to a tumor and hopefully get higher amounts at the target and less systemic effects that can cause toxicity. So I think that is one just general area of excitement that I see in oncology, and I hope that we can continue to build that as part of the imaging cancer manuscript portfolio. Other technologies that emerged recently, histotripsy, the ability, in my simple-minded approach to take ultrasound and blow tumors apart. Another completely non-invasive technique that has the potential for local control, but emerging studies suggest that, that local control instigates an immune response that then can have systemic effects against cancer. So, I mean, I think that is huge. I think the theranostic opportunities are just starting to emerge. They're largely centered on prostate cancer currently, but this is one of the major areas in, I think, diagnostic and therapeutic aspects of radiology that will emerge. Many, many large drug companies are actively involved in this space. And I think it's only going to get more important in terms of its impact on cancer care. And we'll start to move earlier and earlier in the treatment portfolio that is used for oncology. And I think that then it helps position people in radiology to be more of the medical oncologist and really have those type of opportunities for first-line therapy. We've also talked some about artificial intelligence, but clearly that's an emerging area that I think has tremendous opportunities. We talked about, merging information across imaging modalities. I think even more broadly, the opportunity I see with artificial intelligence is to leverage all the information that's available for a patient and really assimilate that into one source of information that, can be shared. A diagnostic radiologist, an interventional oncologist in imaging, medical oncologist. How do we share all the information we have about patients to really make a better diagnosis? Because one of the challenges, I think, in radiology, as we may have lesser direct contact with oncologists on a daily basis, except for things like tumor boards, is really how do we get the information from the medical oncologist to the diagnostic radiologist and merge that information so that we can make a better diagnosis and really understand what's going on with the patient. And I think if artificial intelligence can bring that together and not only diagnose the images better, but diagnose the patient better, that's going to be a huge advance in cancer.
So, how do you feel the use of AI will benefit or detract from our goal of individualized imaging, individualized assessment, and treatment of cancer patients?
I think for AI to make substantial advances in individualized imaging and care of patients, we need to take a step back and think about the development and validation of AI algorithms for imaging and healthcare in general. I mean, at the journal, I see a lot of submissions of AI algorithms that are very effective when they're used in the setting in which they were implemented first and validated. So, meaning a single center, single scan protocol, single approach, single instrument, and everything works great. But then, in many cases, when the technology has to encounter a new situation, so to speak, so you change the scanner, you change the scan protocol, the algorithm doesn't work effectively anymore. You've basically broken the system. And I think that is part of really making AI a valuable part of individualized healthcare is to make certain that this algorithm for whatever diagnosis we want in cancer is generalizable. So if an algorithm is developed on adults, does it work on children, or do we need a new one? If we consider different practice settings, different scanners from different manufacturers, different ethnic groups, different racial groups, does this work? And I think that's an important step that people, developing artificial intelligence approaches for imaging and healthcare really need to address and implement. And then how do these programs adapt and learn? Are there ways that at individual sites that the technology can be optimized? All those are important. But assuming those hurdles can be met, and I'm confident they will be with enough effort and dedication in the field, then I think it makes a huge advance in terms of precision healthcare, precision medicine in cancer, because artificial intelligence algorithm can assimilate information across domains, imaging information of the radiation oncology plan, the treatment plan. All these are valuable pieces of information that are critical for making a diagnosis, determining response to therapy, and then planning for follow-up care. And it's very challenging for any one physician, any one expert to identify all that information, put it together, and then be really facile in integrating all those parts to come up with a single diagnosis or single treatment plan. So I think that the opportunities are great, but the race to get there first may be detrimental to the race to get there most effectively.
For sure. And I think at least the studies that I've seen have demonstrated that AI models do not generalize across different groups of people, do not generalize across different institutions, and in one particular case, do not generalize from adults to pediatrics, which I think is a huge gap in what we have now.
Yes. And I hope that, by raising awareness, not only in this podcast, but people like yourself who are in the field, really see this as a call to action to be able to leverage the full potential of artificial intelligence in healthcare.
Great. I think we covered a lot of the benefits of like individualized imaging and treatment, especially for cancer patients. One of the things maybe we can kind of end off on are some kind of open research questions or barriers that you think exist in terms of making imaging even more individualized. So I know we touched on, right, with artificial intelligence methods, making sure they're more generalizable, they're validated across multiple centers, patient populations, and maybe to some extent, also within imaging, making sure that it's picking up more underlying biological information of the tumor. So, are there any additional barriers or challenges or open research questions that you want to see addressed in the near future? We'll kind of get your thoughts on that.
Yeah, I mean, I think that the ongoing challenge and opportunity is to integrate molecular and functional information into the ways that we diagnose and treat cancer. So, studies that really will there's an ongoing initiative at NIH, for example, in the United States, to integrate liquid biopsy. So, the ability to detect circulating DNA or other biomarkers in the blood with imaging. So that's a big important initiative to really integrate information across all of healthcare. And I think that there are even more opportunities in that. So as there's more information available about the molecular changes that occur in a cancer, that provides information for new theranostic agents, for new diagnostic imaging agents. I think that there's also opportunities then to leverage that in the interventional oncology space. What are the vulnerabilities of a cancer that we identify? And can we deliver targeted therapies to that tumor to take advantage of it? And then going back to something I mentioned earlier, tumor heterogeneity, if one can, from imaging, discern different areas within a tumor that may have unique vulnerabilities, the ability to deliver targeted therapy to specific sites in a tumor or to even specific metastases that may have different mutations, I think that's a huge opportunity. So that means imaging has to be able to detect those differences among metastases in a patient, and then either through targeted interventional approaches or systemic therapies that home effectively to the tumor, those are opportunities. And then one of the great challenges I see as immunotherapy becomes a bigger and bigger part of cancer treatment is our ability to detect and really assess the response to immunotherapy is very limited right now. So CAR T cells, for example, we really don't have great ways to track where they are. What are they doing? Checkpoint inhibitor immunotherapy, our ability to detect the response to therapy typically is months after the start of treatment. Ideally, that could be days or weeks, where there's really a chance in real time almost to adjust the treatment strategy based on the response of the patient. So I think the use of imaging and image-guided therapies to change the early trajectory of treatment is something that will make a big difference for individualized care.
Yeah, that's awesome. On the topic of individualizing imaging and treatment, if you could do one study where you had no restrictions, no monetary restrictions, no personnel restrictions, what would be that research question you would want to pursue?
In my last comment, really touched on the theme that I would like for imaging to be able to address is, can we really start to look at heterogeneity in molecular and functional signatures within a tumor among different sites in a patient who unfortunately has metastatic disease, and really start to be able to tailor our treatment based on that. And, the second trial, since I'm going to be greedy and you've given me unlimited personnel and money, we're going to test a battery of new targeted imaging agents, some of which probably haven't even been considered, yet alone developed. And we're going to be able to monitor the immune system in cancer patients and be able to see why immunotherapy works in a subset of patients and why it doesn't in many. And that information is going to be able to extend the benefits of immunotherapy to so many more patients.
Sounds like a really cool study. Can't wait for it to come out.
Happy for you to participate. We just need a couple $1 billion.
Awesome. Well, yeah, great. Thanks, Dr. Luger, for this really awesome and insightful conversation, and looking forward to maybe having you on the podcast again.
Well, and I thank you for the opportunity. I thank you as new members of our trainee editorial board for doing this. And one thing I haven't really mentioned on this podcast, but I want to before we close, is how much I really enjoy having the trainee editorial board partnership as part of what we do in radiology imaging cancer. We didn't have a training editorial board during the initial start of the journal, and adding trainee members to the board really has helped shape and will continue to help shape the direction of the journal and the areas that are of interest to our readers. So credit to you for your enthusiasm for being part of the training editorial board, and really to help us reach the full potential of what imaging can do in cancer. So thank you for your time. And, I'm certainly looking forward to working with you during the upcoming year, and hopefully, since all of you are first-year members, during a second year too.
Of course. Really glad to be here and really glad to have you.
Thank you for spending time with us today. Special thanks to our guest, Dr. Gary Luker, for his valuable insights. If you're enjoying this conversation, please rate, review, and subscribe wherever you're listening. Your interactions help more listeners find the show. For deeper, evidence-based insights across the cancer imaging spectrum, from screening and differential diagnosis to treatment planning, check out Radiology Imaging Cancer. The link will be in the show notes. Today, you heard from our team, Brennan Flannery, myself, Yash Singh, and Ghazal Zandieh, and special thanks to our editor, Kelly Myers. We'll see you next time on the Radiology Imaging Cancer podcast.